first of all, I'll just show you this slide, which comes from a massive number of data from the US, just to indicate the importance of kidney transplantation to society. So if you look at an age group of 45 to 49, the young age group, we have end-stage renal patients who are on dialysis. This is their life expectancy. So males, 9 years life expectancy if they are diagnosed with end-stage renal failure and they go on dialysis. 9 years left to live on average in the US. And for females, it's slightly less. Probably there's no significant difference between the two. However, if this age group gets transplanted, you get a more than doubling, almost tripling of the, there's a transplant, you get more than doubling of the life expectancy. So if we transplant patients in any age group up to the age of 80 and beyond, there are no data in the US because people are not being transplanted over the age of 80. But up to the age of 79, we see here a doubling of the life expectancy. And of course, these are average figures. People can live, the range is enormous. But it's just an indication of how important kidney transplantation is to society. We double the life expectancy at least of our fellow people. So mortality rates on hemodialysis is about 6% per annum, and if people have diabetes as well, that almost doubles to 11% every year. Kidney transplantation makes a big difference to the lives of these people and their families. So in Cyprus, 70% of our patients are being transplanted from live donor kidneys, which have got a much better lifespan. So we say that on average, a live donor kidney will last about 16 years, and a deceased donor kidney will last about 9 years. And these are the 10-year survival rates for patients and the grafts. Published in 2010, so not so long ago. For transplantation, 5 to 10 years is a good time. It's considered fresh. Very importantly, transplantation is not a luxury. In the times of economic austerity we are going through, it's important that people know that transplantation saves money for the taxpayer. So from figures from the United Kingdom, we know that every kidney transplant saves approximately 30,000 euro. I've done the exchange rate for you as well. So it saves 30,000 euro per annum from the second year onwards. So it's estimated in Cyprus, because we have 70% live donor kidney transplants, that every transplant we do saves the government 400,000 euros for the lifespan of the kidney. This is when Cyprus was the president country of the European Union. I think it was in 2012. This was a slide given to us by the EU Council, and I had to give the presentation to all the EU ministers of health. And it's actually not only in the UK, but it's actually EU endorsed. So throughout Europe, we know that transplantation is not a luxury, it's not a waste of money. It actually saves money for the government as well. So how did it all start in Cyprus? Well, in 1986, the late Dr. George Kyriakidis did his own revolution, brought kidney transplantation in Cyprus, and till 2010, they conducted about 900 transplants to Greek and Turkish Cypriot patients. So the government in 2010 decided to bring all this network of organ donation and transplantation to the government sector. because before, during these years, it was done in a private charitable institution, the Paraskevaidion Center. And since then, the government decided to bring it in the public sector for a qualitative upgrade and also for more regulation. So there was public pressure for more audit, more regulation, and control. So since 2011, we have had a complete reconfiguration of the system. The legislation was modernized with our help of all our team to abide by the EU directives. We have computerized. This is the biggest, I'm most proud of this achievement in Cyprus, that the allocation of organs from deceased donors, as from the new system, is being done by a computer. Before 2010, it was done manually. It's very difficult to conceptualize all the variables that promote good prognosis after a kidney transplant. So we have actually brought the mathematical formula that UK transplant has in the UK. We adopted it to Cyprus, and there is a computer which, for every deceased donor, it allocates points to each person that waits on the transplant waiting list. So it's a very fair system. Every time the allocation of organs is done by a computer. I don't hold the database, so I have no conflict of interest. It's the tissue typing lab that holds the database. They phone me up and they say, look, doctor, we have the first 5 patients from the list are these. So then what I do is I ring up the nephrologist that looks after each one of them, because I don't know these patients, they are all over the country. So they might be in Limassol, Larnaca. I phone up the nephrologist, I say, look, your patient is number 1 on the list. Is he fit to have a transplant? If he says no, he had an operation yesterday, or he had a myocardial infarct, I move on to the second one. And all the decisions, if anybody is eliminated from this list, we record it in the computer, the tissue typing lab records it, and it can be audited and regulated by the regulators who regulate transplantation in this country. So this news has become widespread in Cyprus, and I don't get a single phone call from any MP because they know that the system is very fair. So since this system has been introduced, transparency is guaranteed in Cyprus. So very importantly, the new regulations, the modern legislature has introduced a 10-member council to oversee transplant activities. And I'm also very proud here that this regulatory council of 10 members is spearheaded by patient associations. So in fact, 2 of the 10 members are representing patient associations. So it's for the first time the receivers of the healthcare, the patients, are actually regulating the service providers, which is a very important achievement, I think, for Cyprus. In addition to these 2 patient associations, we have the president of the National Bioethics Committee, Professor Fellas, is represented here. The Pan-Cyprian Law Society is represented here, the Medical Association, and then other professionals as well related to transplantation. So in fact, it's a broad group of interested parties representing all fora and all interested parties in transplantation in our country. For situation, I don't have a vote on this. I'm a member of this, as we are allowed to have 1 doctor related to transplantation on this council in order to give advisory input. But I don't vote in cases where I have a conflict of interest. I move out of the room, and it's done very properly. So we are proud of this. I think regulation is a good thing when it's done properly. We have, since 2011, introduced new techniques, laparoscopic live donation, I will show you later the results and why it's important to do laparoscopic instead of open nephrectomies. Pancreas transplantation, we did the first and only pancreas transplant in Cyprus in 2012. We have done blood group incompatible transplantation, which has now become routine in very developed nations, but we are also offering it here. It's fairly straightforward. I'll show you a publication. We've had the biggest series out of Japan at Guy's Hospital. We published the results. They are excellent. And very recently, we set up a paired exchange scheme, and I'll explain to you how it works out, with Israel. So it's a whole revolution of the system. We talked about the computer software. Same criteria applied each time. It's unbiased allocation of organs. And we are very proud of this. Laparoscopic donor nephrectomy, that means we remove the kidney with the smallest incision possible. Mind you, a kidney is about this big, about 12 centimeters long. So on the side is about 7 or 8 centimeters. So you are bound to do an incision of around 7 centimeters without damaging the kidney. So before 2011, the incisions were massive, 23 centimeters at least. And since then, they are very small, the incisions, as you can see. These are lady donors, this is a man, and they are all thin, as you know, and as you can see. That's because we don't allow obese donors to donate, because obesity can have an effect on the remaining kidney. So we have strict criteria, and if we follow them, we have good results. So this is a publication we published in the American Journal of Transplantation from Guy's Hospital. It was the biggest series of living donor nephrectomies at the time, and it sort of revolutionized this type of operation in the world, because for the first time we proved, or at least we collected evidence, that laparoscopic is safer than the open incision. Because before these papers, there were rumors that, laparoscopic techniques, because of the increased pressure in the abdomen, they cause damage to the kidney and hence maybe worse outcomes. But we have shown here that it is a safe technique and is safer than the open nephrectomy. This is how it's done. So we take the kidney out of this small hole. It's a special gel port. The incision is only 7 or 8 centimeters, and these are the keyhole tools that we use to perform the surgery. Leads to shorter inpatient stay, faster recovery, less painkillers, and in fact some papers have shown that this is also an incentive for more live donation. So people are not so much afraid of big incisions. It's a tiny incision. It's an incentive for them to go ahead and donate to their relatives. This March, a few days ago, we managed to do the 130th operation like this without needing to open the patient. So we've never had to do any open conversion. We did the first simultaneous kidney pancreas transplant in Cyprus in 2012. This is what the pancreas looks like. It's attached to the duodenum. This is the spleen. We remove it before transplanting it. It took us a long time, but the success was amazing for this boy. He was born with, effectively, he developed type 1 diabetes at the age of 1. And since the age of 1 till the age of 29, he was injecting himself with insulin. And since then, he hasn't had to put any insulin. So kidney pancreas transplants are given to diabetic patients, mostly type 1 diabetics, who end up having kidney failure. So if you transplant both a kidney and a pancreas, you resolve both problems, both the diabetes and the kidney failure. And it's not a new procedure. In the US, these type of transplants have been happening since the mid-60s, mid-1960s. So he was delighted that, and he said he went himself voluntarily in a newspaper and just declared his freedom from the insulin. And he said, I now feel very strong, I want to get a job and all that. So it's a massive improvement for patients' lives. We have one patient in Cyprus now who's waiting on the waiting list for a pancreas transplant. We need good organs for this type of transplant. That's why we haven't had many more, and we are a small place. So in the whole of the United Kingdom, around 120 of these transplants take place every year. At Guy's Hospital, we used to do 30 back in 2010. So we modernized the legislation as we discussed. Apart from modernizing the legislation, we have made electronic registers of everything. So we're now monitoring and we are doing prospective audit of our patients and our outcomes, because that's important. We discuss it in departmental meetings so that if we find any issues, we can then introduce corrective measures to prevent this happening again. It's the pinnacle of audit and quality control outcomes. We have a National Potential Organ Donor Register. So anybody can go on the website of the Ministry of Health, and with the press of a button, it's a single page, everybody can declare themselves that they want to be potentially deceased donors, I guess, potential donors after death. And it's just a single electronic form that people can fill in. Now, other innovations, we have written up protocols for donor and recipient evaluation and recipient management. So if patients see various different doctors, but if there are protocols, then the patient care does not depend on which doctor they see. It depends on the protocols. So we all talk with one voice. I think this has made a big difference in our outcomes, as you will see, because we have protocolized a lot of things. Let's go to outcomes in transplantation. Let's go to other countries first. These are the UK results from deceased donation, okay? So if you look at kidney survival and patient survival, 1 year post-transplant, 5 year post-transplant, the average figure for a kidney graft survival at 5 years is only 86%. So 14% of kidney transplants are lost by 5 years. And actually 11% of patients die in 5 years after a kidney transplant from a deceased donor. From a live donor, the picture is more lively. We have 91% graft survival at 5 years and 95% patient survival at 5 years. So remember these figures, 91% of kidneys survive in the UK at 5 years. Similar results in Spain. So at 1 year, this is at 1 year, survival rate in 1 year following transplantation is 93% for kidneys. These are the long-term results, and they drop, as you see, as time goes by. But at 1 year is approximately 93%. At 3 years is close to 90%. In America, California, similar figures to Europe. So in Cyprus, we have got 97% graft survival at 3.5 years follow-up. So we haven't quite reached the 5-year median follow-up, but our results are significantly better than other European countries. Of course, this is a single center study, and the scientists here know that if we compare a single center to a whole country, it's not very comparable. However, it's an indication that we are possibly 2 standard deviations or above the average figures from the UK or the world. And so are our results for patient survival. So Out of 182 patients we transplanted over this 7-year period, we have only had 5 deaths and 6 grafts lost. So going back, our first deceased donor organ harvest and transplants took place in February 2011. In April, we did our first plant surgery from a live donor. And the split between live donor and deceased donor is, as I described earlier, 72% with 28% deceased donation. So, with regards to our laparoscopic nephrectomies, we have done 130. All our donors, of course, survived. The mortality rates from live donation in the US is about 1 in 3,000. So 1 in 3,000 donors die perioperatively in the US. In the UK, no donor has ever died. So it's a very safe operation. But there is a major morbidity of around 5%, and we warn patients. So in our department, it's the only department in Cyprus in the government sector, and Dr. Nikolaidis knows because you approved it as the transplant council then. In our consent forms, we list all the possible complications in detail. And we believe that the informed consent is paramount to get people to enroll, and it improves the doctor-patient relation. If you are honest with your patients, you'll get good results and you have good rapport. So our major morbidity in donation is the same as in the UK. We are lucky in Cyprus because we remove the organs and transplant them in the same hospital. So the cold ischemia time, where you keep the kidney in a bucket in ice, is minimal. So we have excellent results with immediate graft function in the vast majority of our cases, and very few needed a few days of dialysis before the graft started working. We have, of course, surgical morbidity. We are not perfect, and if we didn't have any, something would have been wrong. So we publish our results every year in the Nicosia General Hospital annual report in detail. So we say how many people get a hernia, how many need another operation, and it's a very commendable surgical morbidity, very acceptable if you consider that kidney transplantation, on the consent form, we write 40% morbidity rate. So this is quite a good rate. Of course, we have non-surgical morbidity. So we have had 1 cardiac arrest following a myocardial infarct in day 4, hemopneumothorax. They are mostly cardiorespiratory, the non-surgical acute morbidity. And blood transfusion, only 12 of our 180 or so patients needed a blood transfusion, which is again quite commendable. Late morbidity, it's mostly infections in kidney transplant patients because they are immunosuppressed. But because we follow up patients very carefully and very meticulously, we have a very dedicated team of nephrologists. Now there are 4 nephrologists in our department. We pick up the infections early, we treat them, we have good results. So it's a team effort. Transplantation is by far probably the most team effort specialty in the public hospitals. So we have had rejections, but the rejection, acute rejection of the graft is no longer one of our concerns, because out of the 20 patients that developed acute rejection, we saved 18 of them, and only 3 grafts were lost of rejection out of the 182. So rejection is treatable nowadays. Other achievements, these are the pictures from 2 children we did at Makarios Hospital, so a 3-year-old and a 6-year-old. The only limitation in doing children is their weight. So the 3-year-old was 11 kilos his weight. If they don't have enough weight, their blood pressure is very low and they don't have enough drive to drive the adult kidney, because children receive adult kidneys. And look at if you look at this is their vena cava and the aorta. These are tiny little vessels. They are smaller than the little finger of an adult. And we had to suture the kidneys on these small vessels. So it's a very psychologically stressful situation, because if something goes wrong with a child, they die. They don't have a second chance because of the small vessels, I'm afraid. But they did very well. And I mean, this 6-year-old never had ice cream in her life because she was on dialysis. Ice cream has potassium. So after this, she managed to go to the beach and have ice cream and live a normal life. She went to school. So it's a massive influence in people's lives. This is the other modern treatment we offer, ABO incompatible kidney transplants. So under certain circumstances, we can transplant across the blood group barrier. And as I mentioned, we published the biggest series in the world outside Japan, with 62 patients at the time at Guy's Hospital. And the results of these patients were slightly inferior to blood group compatible live donor kidney transplants, but much better than the deceased donor kidney transplants. So if somebody has an incompatible donor, who is a live donor, it's much better that they go for it instead of waiting on the waiting list to get a deceased donor transplant. They get much better outcomes, more years of life they gain. So we offer it. And this is another way of trying to encourage transplantation in this country. If we have this pair of, say, husband and wife, and they are incompatible with each other, and we have another pair, husband and wife, that they are incompatible with each other, they may be able to exchange kidneys and achieve compatibility in both pairs. So where we had no transplants, we can help 2 recipients receive 2 transplants. The bigger the pool, the better, because the better the chance of finding compatibility. So we have now registered with Israel. They have 6 million population. We have 700,000. And now Greece is thinking of joining up in this initiative. So this will probably hit the news in the next 1 year, which will be great for promoting organ donation and transplantation in our country. When we find the first Israel-Cyprus exchange, the organs will be transferred by plane and the operations will be done locally here and, of course, at the same time in Israel, in case the donor pulls back at the last moment. So we have to do both donations at the same time to avoid such issues, which have happened in the US when the paired exchange scheme first developed. So we've learned from the mistakes of other countries. Finally, this is my last slide, and I've got a thanking slide. We know that the state of kidney transplantation in Cyprus is at least as good as the best centers in the world, and we have got almost 200 transplants to prove this. Very importantly, and I think this is the most important thing, is that there is transparency in the system, and organ allocation is unbiased, equitable, and is well regulated. Finally, as I mentioned, this is a team effort, and these are all the components of the system that we have to thank, specifically the nephrology clinic doctors from all the cities, especially the Nicosia General Hospital, Limassol, Paphos, and Larnaca. The histocompatibility lab, Dr. Varnavidou, who did her PhD in the US, came from the 6th transplant in Cyprus in the 80s, late 80s. And she has now probably supervised over 900 transplants in terms of the compatibility. And we are very proud to have this team with her colleagues, Dora, Galadia, and Richard. Because when they tell me that it's compatible, I know for sure we can go ahead, and I'm not worried that the kidney will turn blue in front of my eyes when I suture it. The anesthesiology team that have kept our patients stable during the transplants, the intensive care team that keep the deceased donors well enough to donate their organs, the coordination team that approach the relatives to seek their consent at the time of their great sadness when they lose somebody so close to them. This coordination team has a great role to play, and all the components of the hospital, medical, nursing, laboratory, and admin, especially cardiology, that have supported us. It's very important to get cardiology clearance, and Dr. Nikolaidis helped us when we first set it up. Radiology, nuclear medicine, histopathology, and our immediate team. We have 4 nephrologists now. The 4th came just last week, so his name is not here. Dr. Soloukidis, Dr. Sava, Dr. Toumasi. Dr. Frangou has now left, but she was there for 2 years. The 2 surgeons that have been with me for all the transplants that we did, Dr. Michail and Dr. Loizou. We had Dr. Prigis, who was a specialist transplant nephrologist. He's now back in the US. He was teaching at the university here. He was present for almost 120 out of the 180 transplants. Our live donor coordinators, our nurse in outpatients, and of course our secretarial support. So thank you very much for listening to me.